Good day, everybody. We still have some people joining us, but we're going to go ahead and get started today. My name is Paige Castro Reyes, and I am the Director of Programs with Community Campus Partnerships for Health. Welcome to Communities in Partnership, Ensuring Equity in the Time of COVID-19. This webinar series is hosted by Community Campus Partnerships for Health and the University of North Carolina Center for Health Equity Research. This series is co-sponsored by the Robert Wood Johnson Clinical Scholars National Leadership Institute, a national leadership program for experienced healthcare providers supported by the Robert Wood Johnson Foundation. It is also co-sponsored by UNC Rural. This new initiative's vision is to connect, support, and engage community campus partnerships to advance the well-being of North Carolina's rural communities. This is the fifth session in our webinar series that has shared powerful and thoughtful information on the current health pandemic. Welcome back to those who have been with us before, and a big welcome to those who are joining us for the first time. I'm joined today by our longtime collaborator, Giselle Corby-Smith, professor in the Department of Medicine at the UNC School of Medicine, director of the UNC Center for Health Equity Research, and co-director of the Robert Wood Johnson Clinical Scholars National Leadership Institute. Before we start today, we have a few ground rules. 1, your audios and phone will remain muted for the duration of the call. Questions to our speakers may be placed in the question and answer box. We will not be able to monitor the chat box for questions, so please put any questions you have for the speakers in this Q&A box. You may utilize the chat to message all attendees during the session. This webinar is being recorded. This and prior webinars are available on the CCPH and CHER websites for review and to share with your networks. We are currently working on transcribing previous webinars as well. We are aware that hackers have successfully accessed Zoom webinars to distribute disturbing images. At any point that we are aware that such attempts are being made to this webinar, we will immediately suspend the session. We believe that such action is necessary to minimize the further dissemination and possible exploitations that might be shared. About today's session. Today's topic is extremely important to me, and I'm so excited that to have our guest today, a researcher and community leader and practitioner, both of whom are committed to the issues of access to quality reproductive and maternal health services during the COVID-19 crisis. This is important to all women and birthing persons, but resonates deeply for Black, Indigenous, and people of color who are disproportionately experience a lack of quality care during the best of times.
Our learning objectives for this webinar are to share diverse perspectives on COVID-19 and its impact on health equity, to develop a network to support systemic changes in response to COVID-19, and to explore collaborations and partnerships in promoting equity in the response to COVID-19. Our first speaker is Dr. Rachel Hardiman, a tenured associate professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. She's a reproductive health equity researcher whose program of research applies the tools of population health science and health services research to elucidate a critical and complex determinants of inequity, racism. Dr. Hardiman's research includes a partnership with Roots Community Birth Center in North Minneapolis, one of 5 Black-owned freestanding birth centers in the United States. Rachel, thank you so much for joining us.
Thanks for having me. All right. I'm just going to get started by sharing my slides, so please bear with me a moment. Oops. Great. So good afternoon, everyone, and thank you for joining us today. I hope someone will signal me if you can't see the slides, but I'm really
so Rachel,
happy.
You might want to put it in slide view rather than speaker view. Yeah.
Okay, my apologies. Oh, I know what's happening. Sorry, technical difficulties. No, it did not work, did it?
No. You can go ahead.
Okay. So can you see the slides at all?
Yes, we can see your slides. We can hear you. We see both the current slide and the one that's upcoming.
Okay, but not in presenter view, or not in
No.
Okay. All right, well, I will start. I will go ahead and get started. Anyways, I apologize for the technical difficulties. I am happy to be here and to share with you some of the work that I'm doing around birth equity and also put it within the context of understanding what's happening within the context of our current healthcare crisis related to COVID-19. So, you know, I'm sure many of you who are on this webinar already are very familiar with sort of what we are facing as a nation when it comes to Black maternal health. We know that there are, rising rates of maternal mortality disparities in our country, and we've seen a lot of the headlines that have described sort of the inequities that are playing out both in our communities as well as in our healthcare delivery systems, you know, from Serena Williams' story to Erica Gardner's story to that of Dr. Shallon Irving, a public health professional who passed away several years ago as a result of complications after giving birth. I'm gonna try again to play from the current slide. There we go. There, sorry about that, guys. So again, we know that we have these rising maternal mortality rates in the US, and that what's happening is that in the United States, we are one of the only industrialized nations, if not the only industrialized nation, that is experiencing sort of these large inequities in maternal mortality and also experiencing a rising maternal mortality rate. Again, here are some other numbers that just really outline what's going on in our country. So in 2007, 34% of Black birthing people experienced maternal mortality, and in 2011, that went up to 43%. And what we also know is that about a third of these deaths are happening during pregnancy, and about 36% are happening at delivery or within a week after delivering a baby. And then about 33% are happening 1 week to 1 year postpartum. So another way of looking at this is that, you know, we know that infant death rates overall have declined since the 19th century. The disparity between Black and white infant deaths today is actually greater than it was under antebellum slavery. Historical demographers estimate that in 1850, enslaved infants died before 1 year of age at a rate of 1.6 times higher than that of white infants. In comparison, the CDC figures show from 2016 show that today non-Hispanic Black infants infant mortality is 2.3 times higher than mortality among non-Hispanic white babies. So that's 11.4 deaths and 11.4 deaths and 4.9 deaths respectively. And the same thing is happening with respect to maternal mortality. So overall, since 1994, maternal mortality has dropped by almost 50% worldwide, yet between 2000 and 2013, high Black maternal death rates have placed the United States as the second worst in maternal mortality among the 31 OECD development nations, so all of the industrialized nations. So while Black women now live longer in the US, the risk of experiencing maternal mortality or maternal morbidity is quite a bit larger than it was many years ago. So the premise of my research is that these current inequities that we're seeing in infant mortality and maternal mortality are very much steeped in the history of our nation and in the 400 years of inequality that Black and Indigenous people in our country have faced. And I think it's important to say that and be explicit about that and show photos or timelines such as these, as disturbing as they are, because it's an incredibly important part of our history, and it has such important context for both the maternal mortality and infant mortality crisis our country faces today, as well as what we're seeing as we watch COVID-19 play out in communities of color across the country. So the root cause of the inequities in maternal and infant health is racism. You know, as my colleague and collaborator, Dr. Julia Perry says, race isn't a risk factor in maternal health, racism is. And some of you may have been on the webinar last week with Dr. Kamara Jones and are familiar with her definition, but just to be clear, when we talk about racism, we're talking about the system of structuring opportunity and assigning value based on phenotype or race that unfairly disadvantages some individuals and communities and unfairly advantages other individuals and communities while undermining the full potential of our society through the waste of human resources. So it's critical that we understand how racism has shaped our narrative about health disparities. And I think it's critical to understand how racism has shaped the narrative about how COVID-19 is playing out in communities of color today, and particularly with respect to to how people are birthing and what those experiences are like. So one part of that, there's two pieces of this that I'll mention in the time I have today. One part is really to understand that, you know, we as researchers, and I think as clinicians, have long used this rhetoric that implies that there's differences between race that are intrinsic and are inherited or biologic. And rather, we need to be understanding and really embracing a public health framing around the social determinants of health that are going to help us to understand how racism has shaped our understanding of health inequities in maternal and infant health and with respect to the COVID-19 pandemic. So we know that health doesn't occur in a vacuum, and I think that something that's become inextricably sort of clear as we've watched COVID-19 play out is that for those who didn't get that before and didn't understand the social determinants of health and what that actually means, are starting to become, to understand more clearly how where we live, work, play matters for health. And how it's really shaping sort of the distribution of opportunities to be healthy, to have access to resources, to have jobs, who, it's determining certainly who becomes, an essential worker and has to continue going to work. It dictates certainly how folks are getting to work, right? If they're using public transportation, it dictates, housing affordability and the options for where people live and the neighborhoods that they live in, and all of these different aspects of people's health and lives are dictated by these social determinants. And what I think is less explicitly discussed and understood is that racism is dictating these social determinants. So, when we think about where people live in the neighborhoods that are disproportionately sort of impacted by COVID-19 right now, we have to understand redlining, and we have to understand residential segregation and what factors and policies over the years and over the history in our country have dictated where people live and why they live in those communities. The other side of this that we have to grapple with right now when it comes to birth equity in the time of COVID-19 is the the numerous studies that have documented Black birthing people's experiences of racism in the healthcare system. So we certainly have more people accessing healthcare right now, given the crisis in our country, but also people are still giving birth and are still having babies and needing prenatal care. And what we know from previous work from incredible scholars like Saraswati Vedam in the Birthplace Lab is that there is mistreatment and disrespect that occurs, particularly for birthing people of color when they're accessing the healthcare system. Dr. Monica McLemore at UCSF and her colleagues have done some incredible qualitative work to really describe the lived experiences, healthcare experiences of pregnant and birthing and postnatal women of color who were at risk for preterm birth. And my own work along with Dr. Laura Atanasio, where we find that birthing people who declined a procedure while they were while they were in the hospital to deliver their baby were more likely to report feeling discriminated against or experiencing racism during those interactions with their providers. So we have these two sides of this problem, right? We have these social factors that are contributing to sort of cumulative disadvantage and chronic weathering across the life course through racism and the social determinants of health. And then we have the other side of this coin where when people are accessing the healthcare system, they are not necessarily getting the quality of care that they need and deserve. And, I would say that together, sort of these things kind of have created this perfect storm or imperfect storm with when we add this layer of COVID-19 on top of it. And we have a lot of work to do to fix that and to ensure that people of color and communities of color are able to birth and get care in the way that they deserve. So I would call that sort of new challenges and old problems, right? So we've seen these problems occur over many years and over decades, and now we have these new challenges that we are layering on top of that are going to have the potential to really exacerbate the inequities we're seeing. The first one I would offer is access and access issues. So we know that hospital and maternity wards are closing across the country. There was a really great piece in the New York Times recently that talked about the maternity care deserts that are developing in communities and predominantly Black communities in Chicago. And, as more and more resources are being pulled into treating and caring for and preventing COVID-19 from spreading, we're seeing more of these maternity care deserts pop up. And what that means is that there's limited access to neighborhood labor and delivery services. Philadelphia is a great case study for understanding this pre-COVID, where what happened is there was a series of hospital or maternity care closures, and what they saw as they tracked that over a 10-year period of time was that as a result, their maternal mortality rate went up. So making sure that people have the ability to birth in their communities and with the providers that they choose and in the spaces that they choose is a hugely important part of access in this way. And I think, as we think about how COVID-19 is impacting access to care, we have to be thinking about how we maintain the resources to allow maternity wards to continue to provide the care that they need to those communities. And then there's the issue of, for those who do have access, there's concern about what's happening sort of within the hospital walls. Many of you may be following some of the stories that are developing right now around the experiences that women of color and Black women in particular are sharing about their experiences when they are giving birth in the hospital systems right now, particularly in New York, where we know the New York hospitals have been hardest hit by COVID to date. So I think this quote's an important one. Pilar Herrero says, "I think where these two public health crises intersect, meaning COVID and the maternal mortality crisis in our country, is that they're impacting the same communities and they're thriving on the same forms of discrimination." And I'll share with you a couple more examples or stories about how that's playing out. So this is Amber Rose Isaac, who on April 17th tweeted about how she was going to write an expose on dealing with what she referred to as incompetent doctors in the Bronx while she was pregnant with her first child. Unfortunately, she was never able to do that because she died less than 4 days after tweeting that in a New York hospital. She had actually reached out to midwives because, given what she was seeing with COVID-19, she had decided that she had wanted to give birth at home or explore that option, which is something that I think is important to talk about. And I know it's come up, I think, already in the question and answer panel. So hopefully we can get to that. But she wasn't able to do that. And I highly recommend you all read the story if you're able, but she ended up passing away as a result of a complication, and her partner has made it very clear that her death was preventable. Another thing that we're seeing is that birthing people are being separated from their babies. So this story was published back in April, I guess early April, by a woman in New York who gave birth, and when she was admitted to the hospital at 38 weeks, she was sick, but not with typical COVID-19 symptoms. So they were unsure of sort of what was happening, but it turned out she had preeclampsia, and after being induced, she gave birth, but then was not allowed to see her child. She wasn't allowed to have skin to skin because there was this concern around COVID. And she, in this story, she really describes how she felt like she was being treated inhumanely and really wasn't supported throughout her experience. And I think things are clearly changing every single day as we deal with this crisis. But one thing that's sort of been consistent from the start is that the experiences that birthing people of color are having at this time are either getting worse, or they appear to be sort of the status quo of not getting that equal care, equitable care. So I just have a couple of more slides that I wanted to share, because I think that it's also important to think about this crisis within and the issues around birth inequities within the context of reproductive justice and what we're seeing play out as a result, or with respect to reproductive rights. So we know that reproductive safety and dignity is dependent on having the resources, right, to obtain both high quality and equitable medical care that's free of racism, and as well as sort of those intersections that, I talked about with respect to the social determinants of health, like decent housing, jobs that pay well, safe employment. And so what we're seeing is that, things haven't changed, that, there's cracks in our healthcare system, I think, that are being revealed every single day right now. And, there's certainly a low value that's being placed on reproductive rights of individuals and of families that continues to be restricted and under political attack. We've seen a lot of sort of politicizing of a public health crisis. And, COVID-19 is certainly shining a light on those cracks and those burdens. And that often is at the expense of community and of patients who are seeking high quality, equitable care. And so, when we think about birth equity in the time of COVID, we also have to think about reproductive rights and the threat that we've seen around abortion rights. So some states have characterized abortion procedures as elective or non-essential during this time. And what we know is that access to safe abortion care is both vitally important as well as time sensitive. And from an equity lens, a racial equity lens, we know that Black people have the highest abortion rates in our country. And so I think that there's this question of, will abortion restrictions during COVID-19 exacerbate the racial inequity gap that we already are seeing in maternal mortality? And there's concern about what that's going to look like as this moves forward. So I try and end on a positive note, and I think that hopefully we'll have time for discussion about sort of what we can do together in partnership and community. I think that right now there's a window of opportunity that's open. We are very clear, if we weren't before, about what's not working, and I think there's a lot of opportunity now to have discussions about what can work, and who should lead that work. Partnerships are clearly very key to that. So the example I would offer is, Roots Community Birth Center, which is a freestanding Black-owned birth center here in the Twin Cities, is thinking about, so there's all of these families, right, that no longer are feeling comfortable birthing in a hospital setting. And it's not a matter of saying, okay, we'll just come here. This is about, this birth center is a better option, but really building partnerships with, between the freestanding birth centers and the hospital systems to think about ways to ensure that families of color and other vulnerable folks are able to get the high quality care that they need and deserve, and that it's safe and that it's respectful and that they get to birth with dignity. And so building partnerships and collaborations in that way, I think is critically important. I would also add that, I think there is an opportunity to lead with equity. So often we're retrofitting equity right into the back end of the things that we're doing. And as we have these opportunities to sort of build new systems and new programs and new ideas, leading with equity, I think is critical to that. And then I would say, this is the time for radical innovation. Again, we are seeing what's not working. And so I know I'm personally excited to think about what sort of new innovation can look like. And I'll end by just saying that I think that innovation has to be intersectional. We have to be thinking about the intersections of all of these multiple identities that are being oppressed and impacted right now by COVID-19. It has to be critical race centered, and anything we do certainly needs to be community driven. And in order to be successful. So I think I will end there, and I look forward to your questions. Thank you.
Rachel, thank you so much for that, as always, a fantastic presentation. There are several questions that came in as people were registering for the webinar about partnerships. Partnerships between healthcare administrators and decision makers, hospitals, community-based organizations to be able to support equity for Black birthing people. Can you sort of share a little bit more about what your advice would be on that? You started to touch on it as you ended your comments, but in particular, this whole systems view of how we can support birthing Black people.
Yeah, I think that we're starting, it's tough because we're always, we're in this moment of sort of reacting to things that are happening, right? But we also need to simultaneously be looking at least, a few months out and thinking about the ways that, these systems can partner. So, the example I mentioned earlier is, thinking about how a community birth center can also support folks who want to birth there, but also there's going to be families that aren't able to access that sort of care, right? Either they're too high risk to birth in a birth center, or their insurance. I mean, a huge piece of it is, will your insurance pay for it? And perhaps, and we know that not all insurance programs are going to cover that. So I think there's a lot of opportunities in that space, right, to think about and to partner and collaborate to figure out how do you wrap, the sort of what those wraparound services could look like, and how do you make sure that people get all of what they need to be safe and to be treated well. I also think, when we're seeing this here in Minnesota, we have an incredible community of birth workers of color who are thinking a lot about both how to vocalize and make it clear to sort of the popular press, like what's happening and where those, where the gaps are that need to be filled and how people need to be supported, and are also, trying to figure out sort of the on the ground stuff of like, how do you, what do people need, what do families and communities and birthing people need right now. And so, one of the best things we can do is like get folks in the same space and in the same room to have those conversations and figure out sort of where where each of us or each sort of entity can contribute.
Your response initially was for the systems and how systems can come together to support birthing people. There's another set of questions around how Black people that are birthing people can advocate for their empowerment at this time, and what advice would you offer to families that are giving birth now?
Yeah, that's such a good question. And it's one that, is certainly going to be, that response, it can be different for every situation. I do think it's important, even if you're not able to have a doula sort of with you, and I know we'll talk about that a little bit more with the next presentation as well, but to still have sort of a plan and your wishes and on paper, and someone who even if they have to be a phone call away, that is ready and willing to advocate. It's hard because I always feel like, well, it shouldn't be on sort of the onus of the person, giving birth and their family to like go in fighting and, having to advocate, but given sort of what we are dealing with. And also, when we think about just how stressed our healthcare delivery systems are right now, and you have to be ready to ask questions and to have sort of a pretty large network of support behind you, whether they can be in that space or not, I think is really important.
Thanks so much, Rachel. There's a number of questions in the Q&A box, so please continue to add your questions.
Sure.
Rachel Hardiman and Rachel and Stevie will continue to try to answer those questions as they've come through, and depending on how much time we have at the end, we'll maybe be able to circle back to both presenters to be able to answer questions. I'm going to turn it over now to Paige to introduce our next speaker.
Thank you.
Thank you. So I'd like to introduce Stevie Marino. Stevie is a doula and owner of Soul and Roots Doula and Placenta Encapsulation. She is an islander in diaspora with ancestral roots from Guahan, Guam, and Boricuin, or Puerto Rico, born and raised in Long Beach, California. She is a longtime community organizer, activist, single mom, birth worker, and academic. Stevie is an anthropologist, where she is currently sitting as the American Anthropology Association Gender Equity elected seat. She actively does research on birth disparities and traditions of Pacific Islanders and Chamorro people. She is co-creator of the Long Beach Doula of Color Training and Birth Worker of Color Collective. Stevie is a full spectrum doula, fertility doula, postpartum support, a lactation educator and trainer. She works with herbs and placentas and different healing modalities. She is dedicated to healing, reconnecting, reclaiming, and decolonizing birth work, community, and self. Stevie, thank you for joining us.
Thank you for having me. I'm so excited to be here and to be speaking about this. There's a lot of webinars and social media, live videos and things surrounding this topic, but I think that this is an important space to be having this dialogue and this conversation. So I'm really honored and humbled to be a part of it. I just want to start with my experience as a doula who has been very busy during this time. It's kind of ironic, actually, because I think a lot of people in the doula world are actually shifting completely to virtual, or are able to stop doing this work at the moment, or whatever it may be, they're not having the same experience. I've actually been very busy and have been attending quite a few births still in person. especially in hospitals, which has been an experience to say the least. This pandemic is something that many have not seen in their lifetime, at least at the way that we are seeing social distancing and all the different restrictions and regulations that the government in different areas are enforcing or encouraging. And so to be in hospitals or to be at births during this time, there's not really a guide or rule book, which has definitely made this work a little bit more interesting. And so, a lot of my perspective is coming from that experience that I've been having over these last 2 months of actively still being in hospital settings and at home births, also acknowledging that that's not the reality of many doulas or birth workers. So this pandemic has not started, but rather exacerbated the ways in which birth disparities, racism, microaggressions are really on the rise, I would say, and is shaping healthcare access and experiences of pregnant and birthing people, particularly pregnant and birthing people of color, not only for maternal health, but also in access to reproductive health options. So some of the things that we're seeing, and that we're seeing all these articles about that I've seen firsthand, are restrictions of labor support and advocacy. Right, so a lot of doulas are either completely being restricted from hospitals, or different hospitals are putting in policies where only one support person or only the partner, if the partner is present, is allowed to be in the hospital rooms. We know and have seen already what the implications of this is, right? And so I'm also very much concerned about what the future implications of that would be. And there are a lot of doula organizations and individuals, especially when we see the example of New York, that have been doing letter writing and campaigns, to kind of go against this. But, I'll talk a little bit about this towards the end, is that there is a real doula divide and doula lines in terms of doulas of color and, the more mainstream doula organizations in terms of whether people should even be providing in-person doula support at this time and whether it's responsible. And so there are all these different narratives that are going on and all these different voices that aren't necessarily centering the experiences of birthing people or pregnant people of color and the doulas who serve them. One of the other things that we're seeing is the separation of birthing people and infants after birth. This was already something that was happening to many of my clients of color before this pandemic, right? Under the guise of, child protective services or marijuana use or all these different things and ways that they're experiencing birth, and not in alignment with the way that research has shown that separation of infants and birthing people is actually potentially detrimental to both the birthing person's health and the infant's health, as well as mental health, right? And so, we also are looking at, when we talk about rights and, being able to advocate for self and all these different calls that are going on in the birthing and in the birth community, in the doula community, about ways that individuals can advocate for themselves. I think we're not thinking about the experiences of people of color, that again, this pandemic has not created a lot of these disparities. These things were already things that were happening in our communities, and now they're just exacerbated, right? And also not thinking about the ways in which a lot of birthing people of color are labeled in hospitals. So sometimes advocacy can equal being non-compliant, right? And how problematic this label can be, but also what are the implications, of the baby and the birthing person not being separated, or not having any issues in being able to take baby home. And once baby is home, what might happen or who might try to enter the home as a result of a non-compliant sort of label. We're also seeing restrictions to access to abortion services, right? In some states, we're hearing that a COVID test is required and the amount of time that the results can take can range from immediately to weeks, right? And sometimes we don't have that amount of time in terms of being able to get the abortion or whatever it is that we need. And then we're also seeing birth control and reproductive contraceptive options, including IUDs, tubal ligation, vasectomies, all being considered elective, right? And so we're thinking about what all these implications are going to mean and what all these different things that are taking place are going to mean in the future, but also ways that it's going to continue to create more and more disparities, especially for people of color and especially for pregnant people. And then we're also seeing social support and postpartum mood disorders. There's not a lot of data out, obviously, because we're still in the midst of this pandemic, but I imagine that there's going to be a lot of research over the years about, the rise of postpartum mood disorders. There's already articles about, pandemic and quarantine fatigue and just the effects that this has had, social isolation and distancing has had on mental health of people. And so we think about birthing people, pregnant people, and this need, right? There's all this research about how important social support is, and community and the village, so to speak, and how now a lot of us do not have access to that because of social distancing requirements, and just making sure that, we are safe and healthy. And then, the last speaker spoke to, these sort of deserts, right? So even when we talk about all these different, I see on like social media and articles that different doula organizations are putting out around ways that postpartum support can look like now. So delivery services for food, for laundry, for all these different things, but not thinking about the ways that certain communities have been impacted and have now, which have already been in play, but now are again being exacerbated, how we're having, essentially like delivery deserts, and not only in terms of access to, hospital and healthcare options, but also in delivery services, in healthy food options, et cetera, et cetera. And then we're also seeing a rise in birth center and home birth inquiries. A lot of the midwives that I work with and that I have relationships with, have been over the last few months seeing an increase in inquiries. And I think it's important to say inquiries because, again, the access to birthing outside of hospitals still has its limitations, right? So insurance is still, for the most part, not covering home births or birth centers. A lot of these individuals are very late in terms of over 37 weeks, which a lot of, depending on your area and the midwife that you're working with or the birthing center that you're working with might not be able to transfer your care at that point. The financial cost is still very real. So a lot of these things haven't changed just because we're in a pandemic, right? And so while a lot of our lives and our livelihoods for many of us have stopped, profit and also access has not just completely been done away with, right? And so this is definitely a barrier that a lot of people are continuing to face. And, a lot of the impetus is falling on a lot of midwives of color, right? Where there is this increase in people inquiring about their services, but also requesting free or low-cost services, right? And so, this becomes this increased disparity amongst birth workers and midwives of color, and, the mainstream doula population and midwife population. A lot of it is also very fear-based, right? I think that, when we talk about medical care and access in the United States, a lot of it falls on the individual responsibility. And so, what I would like to see is really a shift from that individual responsibility to the medical system and these institutions' accountability, right? when, you know, things are being done in a fear-based way from individuals who know that it doesn't matter as a Black woman how much money you make. When we look at Serena Williams, Beyonce even, and all of these different stories of the ways that, you know, they were not listened to, or things that could have been avoided didn't happen, and just the rate of disparities that we know that Black women are dying at 3 to plus that of white counterparts, depending on the area that they live in. And so, you know, really putting the impetus of responsibility on the medical system that is really failing people of color, birthing people of color, Black women, et cetera, and shifting it away from this individual focus, I think is really important. We're also not accounting, I think, a lot for the vulnerable populations, right? These inequities, again, are exacerbated. So we're seeing, you know, again, access, maternity care, deserts, you know, hospitals are closing. And then also looking at the outside of the birth experience and just the economic crisis that is looming that a lot of people are already experiencing. Also thinking about daycare access, right? Where I've had clients, and even for myself as a single mom who has a 5-year-old and is going to birth still, or, you know, physically supporting clients, what does that look like when everyone's supposed to be social distancing? And now I have to figure out what care for my 5-year-old looks like that is safe for him and also safe for my clients and for myself. And, you know, this community ideal of health, right? When a lot of the daycare and preschools and all of the places that our children would normally be at during working hours now no longer have access to. And I think for birth workers, it's this even more interesting sort of situation that we're in, because we're also not seeing it as essential workers. And so, you know, while there are daycares and preschools and kindergartens and all these sort of places that are now opening for essential workers' children, many of us are not seen as essential workers. And so we're also not having the same access that ideally we need. So I do want to give a little overview of how this pandemic has affected birth workers providing support. You know, I alluded to this idea of community division. I think community division has always existed in the doula and the birth world, but we're really seeing that tenfold now. There has been a lot of communication and dialogue around whether it's responsible for doulas to be present and supporting people in person with COVID-19, with this pandemic. And so a lot of people have shifted completely to virtual support. For myself, I had to be very intentional and have a lot of discussion and dialogue with myself, but also, you know, with my clients about what that would look like for them. And, you know, what do they envision care and support, and what are their needs also, right? A lot of my clients, most of my clients are people of color, many of which are single mothers, whether by choice or circumstance. Some are undocumented. You know, for my Black clients who are partnered, who are married, you know, them and their partner coming to the decision that I would actually be at the birth rather than the partner because of their understanding and trauma around birthing experiences, right? And so this community division is really, you know, stark right now. I think, again, we're also seeing the ways that our vulnerable populations are being forgotten in these dialogues, and how a lot of the burden is falling on doulas of color. And, you know, just the ways that doulas have different populations, right? Like my population is predominantly working class people of color. And so, you know, we often hear our doulas a luxury, and we're really seeing that divide right now, where there are doulas who are luxuries, who are saying, I'm going to sit this out. My clients don't actually need me. And for myself, seeing, oh, my clients actually need me more. How do I approach this work and navigate this work with also not being a martyr, right, or self-sacrificing? So I only have a minute or so left. So I did want to just end with, you know, some of the things that I'm really concerned about in the future is what are the implications of a lot of the restrictions that hospitals are making. One of those being, you know, limiting the access to social support during labor, restricting doulas, and also requesting doulas provide certification proof. Many doulas of color, including myself, who has a doula of color training, we are very intentional about not providing certification. And so who are going to be the people that are most affected? I also want to just honor, acknowledge the experience of granny midwives and indigenous midwives and birth workers of the past. You know, they did not have the luxury of being able to decide when to work and when to stop, right? And also the restrictions and certification measures that were put in place in the 1920s through different acts have really over this last 100 years seen how, you know, the shift from predominantly Black and indigenous midwives to white male doctors took place. And I am really concerned about what that is going to look like for this profession in the future. And I really hope people are prepared to continue to advocate for birthing people, for doulas, and for just a better system in terms of medical access for birthing people and pregnant people. So thank you. And I hope we have time for some questions and hopefully.
Yeah. Thank you, Stevie. That was really informative, and I really appreciate you going in and providing some context to just the exacerbated inequities that your clients and birthing people of color are experiencing. One question that we had is somebody asked just what is a doula and what do you do in providing support, and how does that look, you know, pre, during, and post birth?
Yeah, so a doula is not a medical care provider. A doula is someone who provides continuous support, whether that be physical through comfort measures, pain management, spiritual for some, emotional, ceremonial for others. It really depends on every doula, I think, has a different approach. For myself, I'm very rooted in traditional ways of support, whether that be with herbs or hands-on ceremonial techniques. And so, yeah, essentially it looks like providing this added layer of support through labor, through the prenatal pregnancy experience, and also postpartum. My doula experience and scope kind of goes further than that. I also do like abortion doula services, fertility doula services. And so really, again, it's just providing that emotional, logistical, and educational support for people. And now during COVID, a lot of people, again, have, you know, switched to virtual doula support. So being on the phone or on Zoom or on FaceTime while their clients are in labor. So completely hands off. So a lot of people have tried to figure out what that looks like and navigate that. For myself, it sort of still looks the same, except now we have protective gear on. If I did not have access to protective gear, I would not be in hospitals. That's just the reality of also not being a martyr, right? And community health as a whole. And so, yeah, you know, really making sure that we're also social distancing as much as possible. So a lot less hands-on. But yeah, it really has not changed very much for myself personally, though as a profession, it's changed quite drastically.
Thank you. So we have some questions from the Q&A box as well. So let me pull some out here. And Giselle, if you see any on the spreadsheet for Stevie, please feel free to prompt those as well.
Sure, I'm happy to. We had almost 60 questions come in. So Stevie, one question that came in specifically for you, actually, let me pull that up, was around, in which ways does your work as a doula utilize the birthing and community support practices established historically by Black people in past generations?
Yeah, I think that's a really important question. You know, I really try to make sure that in all the work that I do, I really acknowledge the Black midwives and the Indigenous midwives and birth workers, or whatever the words that they identified with, throughout history, as really the shoulders on which we stand, and really the only way that many of us, especially in the United States, are able to do this work, and do it from a space of humbleness, but also in the space of advocacy, right? And so one of the things that a lot of the doula divide also is really focused on is whether doulas are advocates. And I think in looking at, the ways that traditionally granny midwives, Black midwives have really been revolutionary and vital to this work then and now and in the future, and even how midwives, Black midwives currently, are really the ones leading the way, right? And whose voices are hopefully and ideally being amplified and followed, because they are the ones who are really holding a lot of the space for birthing people of color, for Black women, and for Black birthing bodies. Yeah, and just really looking at that example, as I had mentioned, midwives of the past did not have the luxury of saying when they would be able to stop, or, if there was a pandemic or whatever it may be, birth never, it doesn't care about what's happening. It's still happening, and will happen regardless. People will always be pregnant. People will always be giving birth. And so really looking to that example, and again, not in a self-sacrificing way, but in a way that's really rooted in love for community. So yeah, I think that's the shortened version or answer to that question.
We're in our last 3 or 4 minutes, and so I wanted to ask a question of both Rachel and Stevie. What are your highest policy and practice priorities for birth equity from your perspective, particularly in the setting of COVID-19?
Yeah, I think for me, really advocating for support. I think that, again, I think that there is going to be a long-term conversation and need for advocacy around sort of shifting or returning policies back to what they looked like before, pre-COVID. And so hopefully, we are starting to see through the advocacy of many that is shifting in a lot of hospitals. But I think really pushing for that to be where we're at as a whole.
I would say I think Medicaid policy and Medicaid coverage are incredibly important, particularly in the postpartum period. And there's a lot of states that are exploring those options of covering birthing people beyond sort of 6 weeks postpartum. But also I think part of it has to be thinking about all of the options that people have for giving birth and those spaces and the way that they want to receive care, and making sure that they have the appropriate coverage to do that. And I think big picture, what we're seeing, and I think what COVID-19 has laid bare for us, is that these inequities are not solely about health, right? They're about sort of the ways that we have socially disinvested in communities for decades and centuries. And so to me, the big policy we should be having a discussion about is reparations.
Right. Thank you so much. And thank you both for just an incredibly insightful webinar. I want to encourage folks to check out the discussion board on CCPH's website to continue the conversation. You can use this QRS code and just take a picture of it to give us some feedback, or use the website that's listed here. Our next webinar is going to be on May 20th, and we're going to be focusing on community resilience and healing in the setting of COVID. Please stay tuned, subscribe to our newsletter, and you can visit that website there. And I also want to, what's been wonderful about this space is the ability to create community and to create linkages. And so the Center for Health Equity Research will be co-hosting another webinar led by Dr. Wisdom Powell at the UConn Health Disparities Research Institute on racial profiling of Black men